Hello. So my name's Phil Tozer. I'm a surgeon at St Mark's Hospital, and Ian made contact with me via Twitter and told me a bit about the group that you guys have with fistula patients, and I said that I'd be happy to do a chat if that would be of any use, and to talk through issues. If there's anything that you really want to talk about. This is a bit strange. I've not done this before, and of course I can be immediate feedback. I assume that you can hear me. You'll soon tell me if I can't. I'm sure. I'm going to check my phone periodically so that Gillian can me that way as well as via the feed in case there's any technical issues. But otherwise, I'm happy to start talking through. Gillian sent me some questions that people have asked, and I'm quite happy to go through those. I've got them up here on my screen so I can talk through all of them. They're very specific, and I guess that the answer is that most of you guys have had conversations with surgeons or other doctors to talk about fistulas, so you know quite a lot in any case. Nevertheless, it might be easiest if it's okay for me to just run through very quickly a little bit about fistulas, just so that you have a sense of them from my point of view, and it will help with the terminology that I'll inevitably use as time goes on. Gillian's just told me that you can hear me, which is great news for me. So I've done some drawing. This is all going to be very low tech. So this is my picture. I don't know how well you can see that. And this is a coronal section. So you have to imagine that you've been cut with a giant sword straight down like this, and I'm looking in the front, so you can see the anal canal here and the rectum above, and this is the skin of the buttock, and these are the two muscle of the anal sphincter, the internal sphincter and the external sphincter. And of course they are complete rings that run around the anus beside the other. They have different functions, and the whole surgical management of fistula is based around that anatomy. And so everything we'll talk about through will be about that. Now there's one or two different types of fistula that I'm going to tell you about. One more bit of anatomy. This is called the dentate line. Okay, and this is between the rectum and the anus. It marks a change in the lining of the rectum, and it's quite important for us just as a landmark to see what's going on. So I'm going to draw an intersphincteric fistula first of all. So it arises on the inside at the internal opening, then it travels through the internal sphincter, down in the sphincteric space between the two sphincters, and out onto the skin. So the external sphincter here is left completely alone. So it isn't part of the fistula. And then on the other side, a transsphincteric, again, starts on the inside, travels through the internal sphincter, the intersphincteric space, the external sphincter, and then comes out through this space here, which we call the ischial-anal fossa. And these are the two main types of anal fistula. Now, we've also had questions about vaginal fistulas, and they run from the anus or rectum into the vagina, and they tend to go through both parts of muscle as well. In fact, they essentially have to go through both parts of them. And there's also been a question about enterocutaneous fistulas, and they run from the bowel inside the skin of the abdomen. And what the fistula actually is a tunnel of infection that runs from the inside to the outside. In order to treat them, the quickest, easiest, most reliable way to treat an fistula is simply to cut it open. So it starts off like a mine shaft running through the tissue, and we cut it open so it becomes a quarry, okay, open wound. And that's very successful in terms of treating the fistula. The problem is, if I learn that intersphincteric fistula, then this whole shaded area is lost. That part of the ring of muscle can function because it's not a complete ring. Now, a small amount of muscle being lost is no big shakes. And exactly how much muscle be lost is one of the important factors that we discuss when we're thinking about how we can treat your fistula. And that's because doing this, although it has an inevitable act on the muscle, is extremely effective in healing the fistulas. Most of the time, the vast majority of the time, I tend to tell patients about 96 of the time, if you lay open a fistula, it should heal. And that's because in our series, that's what we've demonstrated. Certainly, sometimes a laid open fistula doesn't heal. And that can be for a number of reasons, but most commonly, in my opinion, it will be because there's a little bit of fistula tract that wasn't recognized that's been left behind. Here's an example. Let's say that intersphincteric fistula, little branch going up in the intersphincteric space. You've laid open this lower bit, that's great, but this bit is still buried inside the tissue. And so the either as a sinus, which is a fistula without an opening on the inside, or else it will make its way back through and cause a fistula again. So they do sometimes fail to heal, usually they don't. Now, what happens if we lay open the transsphincteric fistula? Well, then we're losing a lot more muscle. It's the same height, so we're still losing the same amount of internal sphincter, but now you're going to lose function in this part of external sphincter, and so you're relying on only this bit of muscle. And what happens if the fistula does this, which some of them frustratingly do? Then you're going to lose a whole bunch of muscle. Nearly all of the external sphincter will be lost. I should say that as the external sphincter comes up, it jumps to the levator plate. So this is the levator ani muscle, or the pelvic floor muscle. And here, the internal sphincter, circular muscle of the rectum, that's less important. But if we were to lay this fistula open, we'd cut all of this. Now, say that you're a person who doesn't want to have their muscle cut because I've discussed with you what the risk that would be to your control, and you don't like what I tell you, too high to cut without causing a greater degree of control loss than you're willing to accept, then we have to do something else. And at that point, we offer you one of two options. The first is to place a loose seat on and leave it there permanently. And in this patient, that'll be the right thing to do. For most people, a loose seat on should be a comfortable way to control the fistula without too much discharge and specifically without the risk of recurrent abscess. So the whole point of a seat on is to keep the fistula open. Your body will always try to heal fistula, but it will fail. If you leave a fistula without a seat on in, usually the skin will heal over from time to time, and then the pus that's building up behind will build up, form an abscess, apply pressure and pain, and then it will burst out again. And many of you will have experienced recurrent abscesses. The first abscess, which then drained, and then you had your fistula treated in some, or perhaps in the meantime, while you were waiting for your fistula to be treated, you developed another abscess in the same place and it burst out again. And whenever it dries, I know that there's pain coming around the corner because the abscess is building up behind. And it's that cycle of abscess bursting, that the seat-on breaking in there, continuously draining the fistula tract. It prevents the skin from healing, of course, and so any pus cut. And that means that although there is continuous discharge, and always will be if you have a seat-on in place, it shouldn't cause you any more trouble than that. That's the idea. Now, again, if the fistula is complex with branches going here and there, or with a high sump, we call it, with a big abscess. So, for example, if fistula and I placed a seton in it, but there was this big abscess sitting here which I hadn't drained, then you'd have a lot of pus coming from this and quite a lot of pain, because this opening here might not be wide enough to allow pus to drain freely, although it would come a bit. Nevertheless, there would be a build-up and a cavity and a lot of pressure here. And in that situation, in order to make a seton useful and comfortable, you'd have to try and drain this cavity, which we can do in a number of ways. But it can be very difficult, particularly if I. And so that loose seton can be placed as a placeholder just to keep everything quiet and calm while we work out what to do. Or in some cases, it's left permanently because patients say to me, Phil, listen, I like you and you're doing some great stuff, but you're not curing my fistula and I don't think you ever will, and I've had enough and I don't want any more. Please give me my seton back because I was happy and comfortable. I could go to work, I could go horse riding, I could go swimming and do all the things I want to do. Just leave me like that and I'll be happy. That's fine. That's a very reasonable decision, of course, for them to make. But the other option, if we can't lay it open and you don't want to stick with a seton, is to try the sphincter preserving procedures. And the sphincter preserving procedures take many forms. And in surgery, when there's 12 different ways to do something, there's no really good way to do something. Lots of different surgeons will choose one or two of these sphincter preserving procedures and will do just those. Some people like the lift procedure very much, for example, and they will just do that. That's their procedure. They do it time and time again and they get good at it and so on. Other people like fistula plugs or advancement flaps or various other types. In general, your surgeon will offer you one of these different techniques if the fistula is suitable for it. And the trouble with the sphincter preserving procedures is that they don't always work. Now, they usually protect your sphincter and usually will not have any impact or will only have a very modest impact on your continence or control. And really, that's how they're designed. That's the whole point of them. But for them being safe in terms of continence is that they only work, in most cases, in general, about half the time. And an individual surgeon who you're talking to will know their own results and have their own series of patients, and they'll know what they can achieve for you. They may say that it's higher than that. They may also look into the surgical literature to try and divine what the true healing rate is after these operations. But there I would sound a note of caution because the surgical literature in fistula is pretty limited. It doesn't have an enormous amount of detail. The trials done are usually observational. That means we just watch what happens rather than intervening and undertaking a trial in a detailed and thorough way. It means they're less robust in terms of the types of patients they include, the outcomes that they measure, and so on. And they also tend to be quite small, particularly Crohn's disease, less so in idiopathic, in non-Crohn's fistulas, but even so. So that's just a word of caution about the numbers that you will hear. And I think a reasonable, fair guess is that any sphincter preserving procedure is unlikely to work more than about half. That's just a nice rule of thumb. And although they're called sphincter preserving procedures, there are one or two that carry a little bit of risk to the sphincter. And I'm just going to, for my final spiel, stream of consciousness that I'm throwing at you, I'm just going to talk a little bit about continence because it's so important. We've done some work on this at St Mark's. My old boss, who's now retired, Robin Phillips, who really did a lot of the central work around continence after surgery to the anus, has quite a clear philosophy about this, and I think it's borne out relatively well by the evidence, ours and other people's, although again that caveat about the quality of evidence remains. But what we say to you, what I will say to a patient in clinic when I'm talking to them about a lay open is this: the internal sphincter contains what you might call fine control. That provides the ability to control your wind and the ability to prevent tiny little bits of mucus mucus or maybe even a bit of stool-stained liquid from coming out of the anus. And if you divide the anal sphincter, if you don't have an anal sphincter and you're a person who has normal bowel habits, normal control normally, opens their bowels once or maybe twice a day to a firm stool, no IBS, no inflammatory bowel disease, another reason why you might have diarrhea all the time or from time to time, then you can usually expect to have no more than a 1 in 3 risk of difficulty to control and that tiny bit of mucus leakage, which we might call skid marks in the underwear. Divisional sphincter should give you no greater than that 1 in 3 risk. Now, interestingly, if you also divide some of the external sphincter, the sphincter's job is to prevent continence of a greater severity than that, incontinence of a greater severity than that. So if you suddenly you need to go to the toilet and say you clench and try and stop your bowel from opening while you're on the way, it's your external sphincter that's doing that. That's the one you have control over. You can clench. If you're sitting there now and you clench it, it's the external sphincter you're clenching. The internal sphincter is not under your voluntary control. Now, just like your lungs and your kidneys and your liver, there's a bit of redundancy in your body. You've got more of these things than you need. To have one kidney removed and your kidney function is still okay, all other things being equal. And the same is true for the external sphincter. If this is your sphincter and I divide half of it and there's still enough sphincter left behind, then you'll probably be okay. And what we argue is that if there is an adequate amount of sphincter left behind, division of more external sphincter below that, and any amount of the internal sphincter shouldn't give you any more than that same 1 in 3 risk that we talked about. That's a really important thing to understand. It's one of the keys of fistula surgery, and your surgeon will look at this carefully and determine the height of the fistula, which can be done by the examination that you're also unpleasantly familiar with, I'm sure, from your clinic visits. They can have a good feel for where the internal opening is, try and get a sense of where the fistula is. You can't always see that or feel it in the clinic, and so you need an MRI sometimes in order to define that, or an endoanal ultrasound is the other way. Personally, I prefer MRI, but I think an endoanal ultrasound done by a good surgeon or radiologist is just as good in most ways. You can then determine what that height is. And so your surgeon will be able to say to you, yes, I can safely lay this open because A, you're the right patient. Remember what I said about IBS and how often you open your bowels and that kind of thing. And it's the right kind of fistula. And crucially, it's what you want. Because when I say to someone, hey, just a 1 in 3 risk of difficulty controlling wind and a bit of skid marks in your underwear, some people say to me, well, thanks, Phil, but I don't want that. I don't want any of that nonsense. I want entirely to keep my continence exactly as it is. I don't want you cutting anything. That's a very reasonable point of view. So if you fulfill those 3 criteria, then your surgeon will be able to, yes, I am happy to lay this open. There will not be any greater risk than that 1 in 3 that we've discussed. And that's the option that you'll be able to go for. But it is always, of course, another option to go for one of the sphincter preserving procedures, which I can talk about in more detail if that's something that you want to hear. Any particular ones of them we can talk about. But then you are trading that great confidence of success against protection of the continence, by which I mean avoidance of that 1 in 3 risk. If it's a very high fistula, so that I wouldn't be to lay it open, then a long-term loose seton or a sphincter preserving procedures are the main options, and these are the other things that we've discussed. That's a good overview. If anyone has any questions about that, please throw them up on the screen and I'll answer them directly. And if there aren't, or while we're waiting for those, I'll start running down some of the other questions that I've been sent. I hope that's useful. And if so just throw questions at me. So one of the sets of questions that we were asked was about FILAC, which is one of the sphincter preserving procedure. FILAC is a trade name. Laser-assisted fistula closure or fistula treatment is the sort of generic name for it. But I think FILAC is the only player in the game at the moment. I'm going to draw another picture. So the FILAC is a laser that was initially used in vascular surgery. The urologists quite often use it. In fact, the one that we use belongs to the urologist, and they lend it to us very kindly. And what it does is can you see that? Oh, not so well. There, how's that? It's a laser probe, and at the end, right at the tip, the laser gets fired out all the way around, like a chimney sweeper's brush or like a lighthouse, which is firing in all directions at the same time rather than just going around in a circle. And so if you put it inside a tube, it fires out at the whole of the inside lining of the tube all at once. And you pull it back slowly through the tube, burning as you go from the inside, from inside to out, and you close the internal opening, or at least one of the people who promotes, who's worked on FILAC closes the internal opening. Another one doesn't, but probably closing it is the right thing to do. Anyway, close the internal opening and you burn the fistula from to out. And by doing that, you kind of get rid of the lining of the tube of the fistula, and it becomes healthy, bleeding, normal tissue again, and hopefully will have a chance to heal. Arnie Wilhelm is the guy who's done most of these. He works in Cologne. A couple of my colleagues and I went over to see him, and other people around the UK I know do this tech, have done the same thing, gone out to see him to see what it's like, to learn how to do it. And Arnie has published the biggest series, just over patients, and he reckons his success rate in that group is around 65%, more or less. There are one or two other people who have claimed slightly higher rates of success, but with smaller groups of patients, I'm not sure. I don't think it's likely to be a success rate above 65%. Arnie's obviously very experienced, and crucially, he knows very well exactly how to select his patients, and he has quite a strict selection criteria. Those of us who are feeling our way with this, and at St Mark's, I don't know, we're maybe 15 in, something like that, 15 or 20, and getting to grips with this as a technique. That's why I really argue that most people can probably offer a success rate of around 50%, but that may improve as time goes on, or it turns out that you only burn the inside of the fistula tract. The way the energy works and the wavelength of the light that comes out of the laser, the way that it works is that it only penetrates about 2 millimeters into the tissue. So it doesn't the muscle that's deeper, or the inside lining or the outside lining of the skin that's deeper. It only damages that area just around the laser probe. So it's a proof thing to do, and all of the studies have shown either no or very, very slight impact on continence, almost nothing really. The one patient of Arnie Wilhelm's who had trouble had another procedure at the same time, which was probably responsible for it. So it probably has no impact on continence, and I'm fairly happy with patients when I consent them for it. But there are, as I say, strict inclusion criteria, and for example, it won't work if there are side branches. Now, I haven't drawn to do that on my original diagram. Well, I kind of did, didn't I? So this is a side branch of the fistula, and you can imagine that if you put the laser probe in here and you burn all of this, but you don't do anything to this branch, well, that branch is just going to, and when it persists, you don't get healing of the whole fistula tract, and so that bit that you've bed with pus and infected material from the bit that you've left behind, and the fistula will recur. So that's probably why it recurs. And so if I'm going to want to be absolutely clear that it is a single straight tract, probably needs to be transsphincteric rather than intersphincteric, although you can do it, but probably with a lower success rate. No good evidence for that, but it's what we believe. And it probably needs to be quite long, probably needs to be quite long in order to really have good success as well. Long enough so that there's a good chunk of muscle, because that's where the goes down when you're doing the procedure. So that's pretty much about FILAC. I'm not picking up any questions from anybody else. I know that you guys have access to Gillian and one or two other members of your group via WhatsApp and via other groups. Want to put up questions here but can't. And I see that someone is commenting and saying that they have a few questions from others that are unable to comment. Please throw those in. If you can put them on the chat here, do that and I'll answer them straight away. If not, get them to Gillian or someone else who can comment here, or Gillian can contact me through WhatsApp. Let me just check that she hasn't sent me any messages in the meantime. No, nothing so far. Good. So one of the questions that I was asked to talk about is something called Alofisel, or the even more difficult to pronounce Darvastrocel. Darvastrocel is the generic name, and Alofisel is the trade name for mesenchymal stem cell treatment of anal fistula, and it is it's licensed now, and it's about to go through NICE approval. And what they want to do, and what's been done in the past mostly, is using stem cells to treat Crohn's anal fistula. My chat is automatically ethnic. Oh, okay. Gillian's talking to other people, not me. I'm going to carry on. So, stem cell treatment of anal fistulas in Crohn's disease hasn't been used really very much at all in non-Crohn's anal fistulas at the moment. And the reason is that Crohn's fistulas have additional components to them which are making them, broadly speaking, we think that there is a malfunction in the immune system so that it is aggressive, the immune system is overactive, and at the same time, the same factors like TNF-alpha and matrix metalloproteinases and other things, at the same time as damaging the areas to prevent it healing, they also reduce the ability of your body to induce wound repair. So the wounds take longer to heal, and a fistula in that sense is in essence a failed wound. The idea of the stem cells is that they reverse those processes. They reduce the inflammation and they increase your body's ability to undertake wound repair. Okay, a question has just popped up, which I will answer in a second. So, if they can do that, if they can reduce the inflammation and increase wound repair, then it may be that they can encourage those fistulas to heal, or rather stop them persisting. And the main looked at this treatment, which at that time was called CX601, was a big randomized controlled study with a couple hundred patients in, and it showed an improvement in patients who were treated with the stem cells versus those who were treated injection, a placebo injection. Now, they had quite a lot of treatment at the same time. Many of them were on medical treatment. They had closure of the internal opening, and they had quite aggressive curative scraping out of the tract to try and encourage it to heal. But anyway, the upshot was that there was seen in the stem cell group. It wasn't a huge benefit. It didn't lead to a whole bunch of fistulas closing up and vanishing forever. Some fistulas did heal under the influence of the treatment we're very interested in. And it should be coming to the UK later in the year, to start with in only 1 or 2 centres, but it should be coming. Okay, here is a question that has come in. I'd like to know if there is any prospects of cetons being developed that don't have the painful knot. So we should talk about cetons. Just give me 1 second. I'm going to go and turn the lights on because it was sunny when we started. Now it's really dark. Hang on. Turn the lights on. There we go. How about that? Better or worse? You be the judge. So, okay. Cetons. They can be made out of a whole bunch of different things. The first thing to say is that the material choice is really important. They used to be made out of nylon or proline, and these were stiff, inflexible, sharp-ending material, which was horrible, and almost no one does that now, I'm pleased to say. Some people have moved on to something called a silastic ceton or a vascular sloop, and they are very soft, but they're big and bulky, and they're the colourful bits of rubber that you might have seen. We don't particularly like those because we think they're too big and bulky. If you do have one of those, you have an option to tie it like this with a big knot. Or to tie it like this with a few bits of very narrow material, tying it over in a ring. And this is probably a little bit more comfortable, but still not fantastic in our view because it's still quite big and bulky. So we don't use them at all. We only ever use something called bond, but there are other types of this particular material, and it's just like surgical cotton. It's very thin, very soft, and nice. Again, it can be tied in those two ways, and most people will tie it in a knot like this, and they put on lots and lots of knots because they want it to be secure and not fall out. We don't do that. We do it a bit more like this. So we'll tie it with a, this picture is this is my worst picture so far, with a knot in the middle, but with only 3 throws on it, what we call a surgeon's. Now that's not terribly secure on its own. So we then tie back the whiskers with a thin bit of silk, which is even thinner than the original ceton that we've used. And so it's flat, comfortable, low, soft. It's the best one we think that you can make. Now, there is also something called the comfort drain, and that is a material quite similar to the vasculus, but it has no knot at all. It has an internal connection that you can join together. And there's a group out in the Netherlands called the AMC who have done a lot of work in this area, and they've produced another type of knotless ceton, also made of that same kind of rubbery material, which without any knot at all. Now, I think that's very interesting. The lack of the knot is great, but the fact that the material that it's made of produces a bigger and bulkier ceton bothers me still. And I honestly don't know, and no one knows, which of those two configurations is the most comfortable. Those are the only two at the moment which I would really advocate. Okay, there's a few questions popping up, so I'm going to run through them before they vanish off the screen, although I can scroll up. Is there less research in rectovaginal fistulas than anal fistulas? Yes, there is less research in those, and it's because they're less common and also because they're much harder to treat. Fewer people around the country and also around the world do enough rectovaginal fistulas to be able to produce research on them, because they've only done a few cases most of the time, or they might only do 1 or 2 a year, or even fewer than that. We've published some research at St Mark's, the Mayo Clinic has, and various other groups who do a slightly higher volume of them have, but there is no brilliant research on it, very little brilliant research on it. It's one of these which at the Fistula Research Unit at St Mark's, we're very keen to take forwards, and I've got a research fellow starting in October who's hopefully going to do this. It's an area of growth, and we could have a whole separate web chat just about rectovaginal fistulas, which I'd be happy to. It's a big topic, and it will take just as long to talk about as all of this stuff will, and it probably ought to be a separate thing. But I'm very happy to do, or to answer a more detailed question later on. Okay, another question from a member asking whether the hospital you work at gives discharge information to their patients. So the answer is that we do, but as with all of these things, I'm sure that we could do it better. And I know that Gillian and 1 or 2 of the other people here said that a thorough leaflet on discharge summaries would be a useful thing. I completely agree with that. And Gillian and 1 or 2 of you guys are keen to make that. And in fact, the first question that she asked me when we made contact was, would my team be happy to help construct that? And I absolutely would. And I think doing it that way is exactly the right way to do it, you know, with patient experience at the center of it, and with me or members of my team or another group, you know, whoever, clinicians helping to advise and produce it. And I would be entirely up for doing that. I think, you know, It's the 21st century. It would be great to do that in a paper form, but maybe we should also produce a video. And again, that's something I've talked about, and it may well be that would be a really good way to do it. So there'd be a paper form, and there'd also be a video that could be on YouTube, freely accessible for anybody who wanted to look at it. The one thing about follow-up that I do want to talk about is packing. I guess many of you have shiver sent down your spine, and one or two of you will have started to be really miserable. Packing is something which is painful, expensive, inconvenient, and entirely unnecessary in almost all cases. There are just occasional situations where, in order to drain a very high cavity area, it's useful to put something in it. But in my view, the right thing to put in that is usually a drain rather than packing. And in general, the packing of abscesses and fistula is not something that we do. I don't send patients home with packs in almost ever, and I don't think that they provide any value. There's a research study that's just about to start that's going to look at this in a randomized way. I've no doubt that it will demonstrate that there's no benefit and that patients hate it. And we've had it for years. I've no intention of starting. Okay, let me just scroll up because I think I've missed. No, here we go. Another, can I ask what you would do in the case of the intersphincteric fistula with a side branch that doesn't heal with fistulotomy? So that is this patient here. What I would try to do is identify that before I laid it open. But I may not. I may only identify it at the time of the operation. And even if I didn't, it wouldn't make much difference. Having laid this area open, you then need to adequately drain this. Probably the most straightforward way to do that at the time, when it's just it doesn't lead anywhere, is just to open the neck, which is a technical way of me saying that I get my finger and sometimes my thumb and push it up that opening as firmly as I can. You're between the sphincter muscles, so you're not going to damage the sphincters by doing that, as long as you do it carefully and sensibly. And you open up the area at the bottom and you allow that thing fully to drain. And if it can fully drain, then it's likely that it will heal from the inside out. This is one of the situations when I put a drain in, not packing, but a drain. If it's very, very long, and I don't think it's going to heal right at the top very easily and drain from the top very easily, having wide as much as I can with my finger, I might then pass a drain and suture it and leave it there for 2 or 3 weeks to really encourage it to empty out from the top. That's the sort of situation I'm in. That's usually the best way to deal with that. It's probably also possible to use the laser or to use another technique called VAFT to get at the and reduce that track down, but that's not something that's been published. I'm interested in doing it to see if it works, but I will do so only with who know that it's an experimental technique and who want to try to avoid a slightly bigger cut or extension of the fistula. So those are broadly managing it. Part 2, also, how do they identify the branch if an MRI doesn't show it? Yeah, it's a good question. So you can feel it. So if I examine this patient, first of all, I'll feel the external opening. I'll be able to see it and feel it. And then I'll put my finger in and I'll feel the internal opening, see it and feel it. And I'll feel this whole area will be indurated and inflamed. But then my finger goes inside and I press down here onto the pelvic floor and feel sitting up in this area is a bit more induration. It can be very subtle, easy to miss, but in general, I would hope to be able to identify that in clinic and know a bit more to this than meets the eye. In that situation, I'd order an MRI if I didn't have one. If I didn't think that, if I hadn't realized that and I felt that it was a straightforward, simple thing, do an MRI, and in that case, I might only find it in theatre. And that's when I would do the widening of the neck of this extension at the time, and perhaps MRI in the post-operative period. And that's broadly the situation. And sometimes they're so subtle that you just miss them. And in that case, the patient comes back and then you get a scan and you'll see what's happened. Can a low output EC fistula following a different... Okay, so this is one of the questions that I had through and was going to anyway. So this is a patient who's had a hysterectomy and probably an injury to the bowel either at the time or subsequently, a thermal injury or freeze, and a bit of the bowel has given way and is leaking. And that output from the bowel has come up probably through the wound, but it can come up elsewhere. and is now an opening on the patient's skin? The answer is yes. A low output enterocutaneous fistula can sometimes be. Crohn's makes these things more likely. It's mentioned in the question, but you don't have to have Crohn's to have an EC fistula. If they're low output, are working, the patient's eating and well, no sepsis, no obstruction to the bowel, in that situation, it will often settle down, but it doesn't always. And when it doesn't, this is a pretty specialised area of surgery. There are a few centres around the country who are likely to do it more frequently than others. And you would do an operation usually to open down the middle, find the area of bowel which is at the inside of that tunnel of infection, the fistula, remove that bit of bowel and repair it. Sometimes make a temporary stoma, ostomy, colostomy, ileostomy. I'm using all the different words because it's then everyone will pick up what they are. Put a bag on the outside, not always necessary, but sometimes. And then the whole area has a decent chance of settling down. Of course, if the join that we make at that point, then another fistula can appear. But that doesn't usually happen. It does from time to time. However, you never want to do that. Once the fistula appears, you want to wait a year from the last time they had surgery so that everything inside softens up and settles down. You get the patient well nourished and so on, all the other things that I said earlier on, and then you go ahead and do the operation. They're big operations. Redo surgery in the ab can be pretty tough. It will take a long time, several hours of work, and it's probably something that's mostly best surgeons who do it quite a lot. And there, as I say, there are various centres around the country who have a lot of experience of being enterocutaneous fistulas, and they tend to centre around things called intestinal failure units. Okay, what's next? Make sure I haven't missed any questions as I spin down them. A video would be great. Yes. Oh, I see. You're referring back to when I said about the, yes, it would be. I think it's a great idea too. Okay. Gillian, another question was coming. Do you have generic stats on how often fistulas occur in the general population without conditions? Okay. So patients with Crohn's have a 1 in 3 chance of having a fistula over the course of their lifetime. So it is incredibly common. Patients without Crohn's, it's far less common. About 1 to 2 per 10,000 patients, so they're not very common things. But obviously there's a lot of people around and they do happen quite a lot. They're slightly more common in men than women, usually, and they almost always occur after a perianal abscess has appeared. But the abscess and the fistula are part of the same process. People often come to me and say, I had an abscess and then it was drained, and after the drainage I had a fistula. Well, the fact is that the fistula, the abscess appeared because a fistula was forming, and whether it drained itself, I keep reading these, and as I see them out the corner of my eye, it completely derails my train of thought. Sorry. And there's no one here to tell me what I was just talking about. Fistula, but the abscess becomes the fistula. So, you know, they are the same beast, just at different stages of evolution. So, yeah. So, yeah, I hope that answers the question. Is lift a good alternative if FILAC isn't appropriate? No, lift is a good alternative. It's a good thing to do, but usually in pretty much the same situations as FILAC. Let me talk about the lift procedure very briefly. I'll draw a new diagram because that one's starting to get messy and it didn't start out as a work of art. Okay, here we go. Okay, transsphincteric fistula, as we've seen it before. Now, the lift procedure involves an incision here. We run up, dissecting between the 2 muscles in that intersphincteric space until we find the fistula as it crosses between the muscles. Now, this is the area where fistulas are said to start, in the intersphincteric space, with an anal gland. these glands are mucus, and they let their mucus out onto the anus, and that lubricates when you're passing a stool. So instead of mucus coming out, bugs go up and they set up an infection here, and that becomes fistula. So what you do is excise this part of the fistula, take it away, and you close off one end here by this muscle and here by this muscle. So you've got rid of the central nidus of infection, and you've disconnected the rest of the tract from the internal side, from the internal opening. Just like Phylac, it only really works if you've got a single straight track. As soon as you've got a side branch, then you can't operation very easily. You can't get around this area in the middle and tie it off. And even if you do, there may be a branch that you leave behind. So there can't be any tracks here, certainly. If it splits out here, that's okay. It's this area where it has to be a simple tract. Otherwise, the lift procedure isn't appropriate. Probably works about half the time. There's a cut around the anus, usually for 2 or 3 hours on the clock face. So if you've got a fistula opening at 2 o'clock, then I'll usually open 12 or 1 and 3 or 4. You open it like this, and then you can burrow up in that direction and narrow down onto it, something along those lines. And it probably works in about half of people. The recent study in the UK, the Fiat study, suggests that in that group, it probably only works in about 40%, but it was a small patients spread over quite a large number of surgeons. So there wasn't anyone who was doing a very high volume and entering them into the study. I'm not sure if that's truly representative, and the studies from elsewhere have shown higher healing rates, some of them very, very high, which I'm not so sure about either. And I think 50% is probably a fair bet in most people further around. Okay, let me go further up. That was the lift question. Okay, what are your thoughts on sits, baths? I'm quite happy for patients to do them. They can be very soothing and help in terms of comfort. I don't think that they will have any impact at all on your chance of healing. But I think if the wound is wet for too long, it can become macerated and less likely to heal. So I don't mind people doing them, but I don't suggest people sit at very long periods and get all that tissue really macerated and wet. The best way to look after a fistula wound after an operation is, assuming you're allowed to get it wet, and essentially in pretty much all cases you are, but your own surgeon will tell you what they've specifically done and what they specifically want. But for my patients, I tell them to hop in the shower and get the shower head off the wall and hose the area down from underneath. I tell them that it's a good idea to do that a couple of times a day, and certainly if they've passed a motion and there's a bit of smearing of stool around, you want that out of the wound. And so again, I'd just get the shower hose and give it a good rub down. You can rub the fistula wound as well. And in fact, instead of packing, I tend to encourage people to rub the wound. We call it digitation. If they've had a lay open, to rub it, and that will perhaps stimulate healing, but certainly stop the skin from healing over too quickly, and hopefully should encourage it to heal from the bottom up, which is the reason that people give for packing. Like I said, I'm not a fan of packing, but digitation is quite a nice way to deal with it. I usually tell people to start doing it a couple of weeks after they've had a fistula lay open, not for lift, not for advancement like any of the others. It's only if you've got a lay open, and again, your surgeon would tell you if they thought it was a good idea. It depends where the wound is as well. If the wound's inside, you can't reach it, and I wouldn't go near it. But if there's a wound on the buttock, then I sometimes encourage digitation. But that really is one to discuss with the surgeon before you start fiddling with the fistula, because they may have done something that they don't want you to touch, like an advancement flap. What about cushions? Yeah, again, donut cushions and so on. I think the best thing is simply to make yourself as comfortable as possible. And usually having 2 or 3 soft pillows or cushions underneath you is better than using a donut cushion. And I think I would advocate that. I think it would be unusual, except in the case of an advancement flap, particularly one that comes from the outside in rather than the inside out. I think that's really the only situation where sitting is likely to cause a real problem. Otherwise, you're not going to really damage anything in most cases. But it's one to discuss with the surgeon whether they want you to sit on or not. That it does depend specifically on what's been done. In general, just being comfortable with soft pillows is the best way. And if it's not working out, then look at it afterwards. Can radiation therapy cause issues with healing with fistulas? My doctors don't understand why I'm not healing. No Crohn's or IBS, they're attributing it to radiation. So yeah, it can. So there's two situations when people get fistulas in association with radiation, or where radiation has an impact on fistula healing. Broadly, two situations. And those are radiation for prostate cancer in men, or for cervical cancer. Anorectal cancers as well. It seems to be a bit less of a problem there. But anyway, yes, irradiated tissue doesn't want to heal. The tiny blood vessels right at the end have been damaged, and the blood supply to the tissues is not as good as it should be. And that means that fistulas really struggle to heal in the presence of radiation. It is sometimes necessary, not always, to bring healthy tissue from out radiation fields down in order to do a fistula repair. And that can sometimes mean doing a much bigger operation than you would normally do for what's physically, at least, a relatively small problem. That's not to underestimate the impact that it has on people's lives, which I completely understand is enormous in some cases. But it can be necessary to do that, to bring healthy tissue from outside the radiation field down. And we do that from time using something called a coloanal pull-through, most commonly where there has been a rectovaginal fistula or anastomotic fistula. That's when you take out a chunk of bowel for cancer and the join that you make leaks, and that leads to a fistula in the presence of a radiotherapy field. In case it's sometimes necessary to bring an area of the colon down through the tissues and to make a join inside the anus. Again, we don't have time to go through all of that. It's a really big deal, much more significant operation, plenty of side effects that patients often don't like, and it's something that you would talk through with a specialist in quite a lot of detail. But that is sometimes necessary, yes. And if you've got a fistula or a wound that absolutely refuses to heal and it's in a radiotherapy, that is the kind of thing that ought to be discussed, at least. You may not like the options that are offered, but it's the kind of thing that I'm in my clinic from time to time. Question messaged: how do I get my surgeon to take me seriously, especially pain levels? As a doctor, what language gets through best? I often don't get taken seriously. I bring my husband with me. It's difficult, isn't it? People surgeons absolutely understand that this is a horrendous situation for a lot of people. For some people, it's a very modest thing. They have a fistula, you lay it open, everything gets better, there's no impact on continence, everyone's happy. They don't think of it as anything more than any other thing to the doctors for. And then for a small group of patients, it's completely miserable with years of repeated operations, recurrence, difficulty with discharge, pain, stops you going to work, stops you having sex, stops you playing sports. We completely get that. In addition to all of that, of course, it's exactly the kind of thing that no one wants to talk about. And it's an invisible thing for the majority of people around you who have no idea what you're going through. Whilst we understand that, there is sometimes just not very much that we can achieve. And it may be a situation where you're going to your doctor saying, everything is awful and I want you to do something. And the surgeon's response to that is, I understand everything is, I've tried everything that I can, and there's nowhere else for us to go. And that is a really difficult and miserable situation for everyone, most of all, of course, the patient. To answer your question more directly, if you don't think that you are getting taken sufficiently seriously, then it may be possible to bring that up with the surgeon that you're talking to. You may not want to. And even if you do, it will be effective. And in that situation, it is reasonable, in my view, to ask for another opinion. And that's not to say that the opinion has given you is wrong or that you've done anything wrong. It's just that sometimes the doctor-patient relationship doesn't work out for whatever reason. And in that situation, with somebody else can be really valuable. Not least because if the other surgeon says the same stuff to you, then you know it wasn't personal and an error. It's just that that's what it is. But it may be that you and that other doctor have a better relationship and can communicatively. And I've no doubt there are people that I've seen who just didn't like me. He just didn't like the way I said things and the way I spoke, and I made some joke at some point to try and lighten the mood, not that I was inappropriate. I'm sure these things have happened, and in that case, getting an opinion from someone else, so we don't mind that. We don't take offence. If you go and see someone make you better, great. I mean, that is exactly what we really want. So I don't think you should feel anxious about that. And it may be someone else within the trust, or it may be someone in a local trust, someone, a specialist from another trust who has a particular interest in this area. These things are all possible, and you can always do that by chatting to the surgeon or by chatting GP and saying, hey, I was hoping I could get a second opinion. They can refer you on for that. So those things are all possible. Okay. Who is most likely fistula? How much of physical activity and lifestyle related to causing it? Okay. Over this a little bit. Fistulas that are not related to Crohn's or to another underlying disease or problem like radiation or surgery are slightly more men, and it's usually men in early to middle age. But it can be very young people and it can be very old people. And in those situations, tend to look for another reason for it. But it can be anyone, but it's usually that group of people, men and women, but men slightly more commonly in that middle patch of age, 30s, 40s, 50s, that sort of age. It's pretty unusual that your own physical activity or lifestyle is going to be related to it. If something you're doing is leading to recurrent infections in the area, then I suppose it is possible the fistula is more likely to appear. But if you were, for example, worried about anal intercourse or about sighing or spending a lot of time in a lorry, one of those kinds of things, those things probably don't have an impact and aren't likely to cause commonly, although of course in an extreme situation I guess they could. But in general, it's just not your fault. It's just one of those things that an infection has appeared. There are certainly people who are more prone to getting these infections in the first place and who are more prone to that not simply resolving, but to going on to cause a fever. But we don't really know who those people are yet, and trying to work that out is one of the areas of research which is currently very interesting, certainly in my opinion. Hodgkin's 22 years ago, above diaphragm with 8 months of therapy, so I'm not sure of that. So it depends where you have the radiotherapy is. If you have external beam, I'm going back to the previous question that we talked about now, if you have external beam radiotherapy focused around the anus, and that is by far and away the most likely cause of a fistula, or a fistula failing to heal, or a wound failing to heal in that area if it has occurred. Whether it's it depends on where you had the radiation, but yes, radiation damage to the anus certainly can have an impact on fistula healing. What's the best way to tackle horseshoe fistula with multiple branches? This is a good question. It very much depends on the morphology of the fistula. The first thing to do is drain the sepsis, drain the abscess, and insert cetons. And exactly how those cetons inserted depends on the nature of the fistula. Quite often, you have abscesses left and right, which are horseshoeing round to the back, and then the opening into the anus is there at the back at 6 o'clock. So there's only one internal opening, one part of the fistula sphincteric, and then it runs outside the sphincter complex in a horseshoe shape and comes out as abscesses on either side. In that situation, the thing is to put the cetons in from the openings up into the internal opening via the existing track. It's crucial not to make an additional track. Of course, you can have multiple fistulas, more than one internal opening and more than one external opening, going in different tracks at the time. But the horseshoe situation that you're talking about, usually this. Once you've done that, you then have to deal with the horseshoe. Now, there are different ways to do it. Some people will place a seton through the horseshoe itself, really scrape it out thoroughly, and then remove the seton in the hope that it will settle down and heal, draining it both ends. The most surefire way of getting rid of that horseshoe is to lay the whole thing open. And because you're not cutting across muscle, but running within the horseshoe plane, so muscle will be next to you, but you won't be crossing it, you can do that without risking continence, but you can end up with a wound, which can take 4 or 6 or 8 weeks to heal, sometimes even longer, and will be painful. You might be in hospital for 2 or 3 days because it's so painful and you need lots of analgesia until it gets a little bit more manageable. So it's quite a big deal, and lots of people don't really want to do it. And if you're well controlled with setons, for some people is enough. Other ways to try and deal with that are experimental. So one of the things I'm doing at the moment, experimental is the wrong word, but are not well proven. And one of the ways that I'm trying to do it in some patients is to burn the tract from the inside, use the VAFT, and that's where you get a little telescope which you can put inside the fistula, and then you can burn it a bit like the laser, but you're doing it with diathermy. So you can do it under vision, you can see all the bits that you're burning. And the idea is trying to settle that area down without having to make the big cut. And some patients are keen for that because they don't want a big cut. You know, they can't take the time off work, it's too painful, and so on and so forth. How successful that is, I don't know. We have to wait and see. But for some people, it may be a viable option, next option. Ultimately, I'm expecting, in most of those situations, to have to lay the fistula open, ultimately the horseshoe open. Once you've done that and you've got transsphincteric tract, well, then you can do lift or FILAC or one of the other techniques that you want to do, VAFT or advancement flap or whatever your particular interest in procedures is. Why do fistulas flare up, swell, get inflamed, drain feces when setons are in? Okay, sometimes that's to do with secondary tracts. So if you've got a seton in a primary tract, but you've got a big secondary extension, like this one I showed you earlier, there's a seton in here, but this big cavity remains. That seton can't really manage that. We call that a high sump, and it just continues to pour down stuff, and it's inflamed and painful and so on. So in that situation, it's ideal to try and drain that. There may be side branches that are going off, and you may get little abscesses at the end of the side branch because part of the branch healed, so it can't drain via the seton anymore, and you get a little abscess in that situation, and then it bursts through and you get a bit more pus, or you don't even notice perhaps, but pain settles. Sometimes people will go in and lance those separately. So it can be that there's a cavity which is not well drained. And usually if someone comes to me and says, I've got a seton, but I'm getting continued, I do an MRI scan and then I take them to theatre and I go hunting for these undrained areas of infection, which I can get access to and drain thoroughly, maybe with another seton, maybe a cut and draining, maybe by getting the VAF scope up into there to try and get them drained and then see if that settles things down. They can seize because they are a tunnel, literally, and open at one end and they're open at the other and they're open all the way in between. And if a bit of stool gets in there, it can make its way down the fistula. And that usually depends on the caliber of the fistula. If it's a great big wide thing, obviously not this wide, but if it's a big wide thing like this, then 6 millimeters across or more, all the way along its length, then you can get stool coming down it. They're very often narrower than that, if not all the way down. Then at least in one or two places they go through the intersphincteric space between the muscles, they hourglass in together and then go wide again. And in that situation, stool is less likely to go down. I think that's probably the most likely answer. Some people who have a seton in argue that if they pull the seton through with the knot brushing through the fistula, that just helps to keep things. That's a very reasonable thing to do. Can a rectocele cause a fistula? Should it be repaired? That's another question I was going to come to from the list that I was sent beforehand. Rectocele fistulas. A rectocele is a weakness in the tissues between the rectum and the vagina, which allows bulging of the rectum forwards into the vagina. However, they are incredibly common, and what you might call a physical rectocele occurs in a great many women. And there were radiographic studies done a couple of decades ago now, which demonstrate that a large proportion of women just have a rectocele and are walking around, don't know anything about it, and it doesn't cause them any trouble. So the presence of a rectocele in isolation is something that necessarily needs dealing with. Now, if you have a rectocele that's causing obstructive defecation, meaning difficulty in opening your bowels, then it may be worth repairing it. How can you know? Because you might have obstructive defecation for another reason and have a rectocele, or an unnecessary rectocele repair. Well, usually, certainly in our unit, if we're going to do a rectocele repair, we first of all have to think there is one. We then have to demonstrate that there is trapping on defecating proctography. That means that's a particular type of test. A dye up into the bum, we get you to do a poo to pass all that dye out on a commode whilst being x-rayed. I'm afraid there is very little dignity to be found in the colorectal clinic and the test that we put you through. We do try to maintain dignity and respect things, but there is an extent to which, it's very hard to make that situation dignified, although the radiographers are very good at treating people respectfully and kindly in the patient. It is nevertheless something that a lot of people find daunting. Anyway, that's the test we do. And if some of that dye doesn't come out, it goes forwards into the rectocele and and the patient finishes, stands up, and all that sits back into the rectum, well, then that's probably a symptomatic rectocele. The key bit of information for us is that they will often come in and tell us that in order to help empty the rectocele, they do something. Press somewhere or whatever, empty it. And in that situation, a rectocele repair is perhaps more likely to be significant and more likely to mean that symptoms will improve repaired. And then it can be repaired by colorectal surgeons or gynecologists, and it depends. But it's something that a pelvic floor unit, of which there are lots scattered all around with pelvic floor interested surgeons in them, can go into with you in great detail. It's a very personalised thing. They need to see you, examine you, talk to you, and test before they went down that road. It doesn't cause fistulas, but it can come in combination with them. If the rectocele is caused by traumatic delivery, rectovaginal fistula is another thing that can be caused by traumatic delivery, and so they can sometimes come in combination together. And then the repair would take a different, be slightly more complicated, but they can occur. But if you have a rectocele, it's not going to cause a fistula. If you have a fistula, it's not going to cause a rectocele. Stating active and inactive fistula. What is an inactive fistula? That's a good question. So an MRI will tell us if a fistula is present, and sometimes they're bright white, full of inflammatory tissue and fluid. Sometimes you can see the track. You can make out there is a track there, an internal opening, an external opening, and a line that goes between them, but it's not white, it's not full of fluid, it's not highly inflamed. We might call that an inactive fistula. It would be scarring from where a fistula has been and has healed. But that's really what we talk about when we're talking about an active and an inactive fistula. That's not an exact science. It's helpful to us, and so radiologists tell us about it. But it's much more important to hear how the fistula is doing. If it's draining, then it's obviously inactive, but it helps us to understand about the inflammatory activity in the fistula. Probably more useful in Crohn's disease under medical treatment, so that we can see if there's a change time in the inflammatory activity. Final question as we're running out of times. Oh, that's it. That was the final question as we're running out of time. Very good. Not at all. You're absolutely welcome. It's a really complex area. Final thing that I want to say is I've talked about things very generally, and when you are sitting in front of your surgeon and they're telling you something, it sounds like they're telling you something different to what I'm saying. That's probably because they know more about your fistula than I do, and so there may be differing bits of advice, but in general, I